Good evening, everyone from Dubai. This is Dr. Humaira Badsha, and we're really looking forward to welcoming all of you. We have about 400 participants from around the world. We can see 130 are online already. And I'm very excited and pleased to introduce Professor Carlo Selmi. He has an MD and PhD from the University of Milan, and he's head of rheumatology and associate professor of medicine at the Humanitas Research Hospital in Milan. But most importantly, he's been at the front lines for the past several months in Italy, which we know has been devastated by COVID-19, and he's going to share his insights with us today. So welcome, Professor Carlo Selmi, and we look forward to your talk now.
Thank you so much, Mira. Thank you all for being here. Yes, this is a very strange time, totally unexpected by all means. A couple of months ago, maybe 3 months ago, we were discussing about quality of life, about biomarkers, about clinimetrics, about you name it, classification criteria. And out of the blue, we became all involved in something completely different. As of March, as of the last week of February, all our outpatient clinics were closed throughout Italy. And we were all catapulted to the front line of the coronavirus clinics. So I live in a region which is in the north part of Italy. It's the region of Milan, which is called Lombardy, which has about 10 million people. And the area of Lombardy became the epicenter of the coronavirus infection. Right south of Milan, in a small town called Codogno, we had the first patient with coronavirus in Italy. And from then we had little foci all throughout the country, especially in Lombardy. As of now, we have had approximately 20,000 people who died of coronavirus. And that is something that clearly made an enormous impact on the way. Entire hospitals have become fully dedicated to coronavirus. In my case, the clinic was closed. So I was asked to go to Bergamo. Bergamo is a city of about 100,000 people, which is east of Milan, about 50 kilometers east of Milan, and has been an enormous center for coronavirus. The same hospital where I work in Milan, which is Humanitas, owns a smaller hospital, which is about 270 inpatients, which was completely devoted to coronavirus and still is in a way. And this is where I am broadcasting from right now. So this is what I will try to talk to you about today. What happened and what is currently happening in this country, which you see represented at the bottom here. This center you see here is Milan. This region underneath is Lombardy, the one I was talking about. As you can see, there's smaller areas throughout the country, particularly in the northern regions. The southern regions have been quite spared so far. Then the second point, I will try to tell you how rheumatology has come to be.
Professor,
I'm sorry, I'm here. Sorry, there you go. Sorry, the video is sort of going on and off. But so how rheumatology became extremely important to anybody dealing with coronavirus, because most of the mechanisms of disease are shared with rheumatology, and we'll talk about that. Many of the drugs that are being used or are being proposed to be used against coronavirus come from rheumatology. Third, how has the rheumatology practice been affected by coronavirus? And last, how EULAR and Italian rheumatology recommendations tell us to behave in the case of to deal with our patients. So let's start. What is happening and what happened? Well, we all know what coronavirus is. It's a beta coronavirus, which appears to be the result of a spillover, probably from another species. The species most involved appears to be bats. I did not know that, but bats have about 1,000 different subspecies. And apparently only 2 or 3 of those seem to be affected by the COVID-19. The infection can be leading to a wide spectrum of symptoms, from very mild to life-threatening, the result of which can be a severe acute respiratory distress syndrome, ARDS, possibly leading to a multi-organ failure. About a third of them will require invasive ventilatory support and in the setting of ICU. Mortality rates are widely varying with the areas in which they have been described and the timing in which it has been described. When all of this started, the earliest Chinese series from the Wuhan city region, which, as we all know, were the first ones to describe the virus, were about 2 to 3%. But in some areas, and especially at some times in which the inpatient opportunities were lower, and in which the selection of patients had to be more severe, went much higher than that. What the earliest references, especially the ones from retrospective Chinese series, showed that a poorer prognosis was seen in men and older patients, particularly in those with comorbidities. And that, to us, is probably not very surprising. From a clinical standpoint, we do know that most patients have respiratory disease, but largely the most prevalent symptom in symptomatic patients is fever. According to the earliest series, approximately 85% of patients with clinically overt coronavirus infection had fever. And approximately 50 to 70% of patients had respiratory symptoms. These went from upper respiratory tract symptoms, such as rhinorrhea, sneezing, sore throat, to all the way to pneumonia, largely dominated by an interstitial pneumonia. That is what we're used to see in the connective tissue disease spectrum as a ground glass opacity, all the way to ARDS, acute respiratory distress syndrome. In the case of systemic symptoms, we've seen a wide variety of possible manifestations, including hemoptysis, including acute cardiac injury, particularly myocarditis. We have had at least 3 cases which have seen directly of patients with a very mild respiratory picture at imaging, but largely dominated by myocardial inflammation. Hypoxemia all the way to dyspnea. Lymphopenia is probably one of the dominant manifestations in the from a biochemical standpoint. Other signs of disease include increase in LDH, lactic dehydrogenase, elevations in transaminases, elevations in CRP, generally associated with a normal procalcitonin level, increase in ferritin levels. And that is why, according to some authors, the disease seems to have different immunological stages, starting with the largely viral infection to begin with, migrating to a more auto-inflammatory manifestation, largely driven by IL-1 with an increase in ferritin level. So low lymphocyte counts, increased LDH, ALT, C-reactive protein is very important and virtually found in all the patients with coronavirus infection. So this became rapidly, led Italy to rapidly become, over the next 6 weeks, the top country in the world in terms of the speed of infection. These are data from March 24th. That is approximately 1 week after, 4 weeks after the first case, in which you see that the mortality was highest in this country. And if the earliest report showed a mortality rate approximately 2-3%, we witnessed a brisk increase all the way to 10% as the end of March. As you can see, countries that were supposed to become later on leading the pack of coronavirus infection were still tagging behind, especially in the case of the United States. Probably, however, what we should note is that comparing these figures is very difficult because not all countries had the similar case finding methods. That is, not all countries did a pharyngeal swab in all suspected cases. Probably the case in which swabs were least performed included Germany, for example. And the other reason probably for the higher mortality was that Italy is indeed one of the most rapidly aging populations in Europe, if not worldwide. So that is what led at the beginning of March to a complete lockdown of the country. So now for about 6 weeks, nobody can leave home except for serious reasons. Maintaining social distance, which is supposed to be 3 or 4 feet distance from anybody, including at least a surgical face mask wherever they go. And with the exception of medical reasons, other emergencies, or for grocery shopping. So that led to a complete freezing of the country. Only a handful of industries were allowed to continue working during these times. And those were largely related to major needs, food chain, delivery chains, but schools have been closed since, and people have been constrained at home. And that is led to, finally, to some major effects, because we've finally seen a plateau reached by the infection incidence. And finally, we are witnessing a slow decrease in the slope. And that is why several people in the country, including politicians, are calling for reopening of the country. And there's a big fight right now about what to do in the next weeks. Because of course, a lockdown country poses enormous social and economic challenges, as you can imagine. Lots of people are becoming poorer and poorer. Lots of factories and industry are starting to close down because they can't afford to remain closed and locked down for many more weeks and to pay salaries. And that has led to great social issues, which are probably beyond the aims of this. What did Lombardy do? Well, we had to completely transform our way to take care of patients. And probably what had to change most significantly was the ICU capacity. To begin with, Lombardy had about 720 ICU beds. And this has changed completely. Number one, because all non-urgent procedures were canceled in slow ramp up of the procedure to be canceled. Everything, they started from very non-urgent procedures, including, I don't know, aesthetic medicine, plastic surgery, ENT surgery, all the way to oncology. Why was that? Well, obviously because oncological surgery usually is a major surgery, and major surgery is expected to be needing ICU beds. And that is something that at the present time we were not capable to guarantee to the patients that had to undergo. And again, this started 6 weeks ago. That implies that all patients who had a planned surgery or any other planned treatment that was considered to be non-urgent to begin with was postponed and still is expecting a time for surgery. It went down to approximately 90% of surgery being postponed in the time of 2 weeks. And that was something that is creating an enormous backlist right now of patients waiting to be called. The ICU surge capacity was done in a regional effort. So it started by identifying hubs. Hubs were hospitals that decided to transform particularly surgical wards into ICU beds. Our hospital tripled the number of ICU capacity within 2 weeks. So large surgical ORs became ICU inpatient clinics. And that largely followed the ECMO, the extracorporeal circulation respiratory failure network, which was well established in this country. So most of the hospitals involved in this network starting. This led to another inpatient change, which was to create separated tracks for COVID patients. The one thing we needed to identify was how to cope with patients who had a coronavirus infection, but number two, to make sure that those patients remained separated from the patients that were not coronavirus infected. And that led to an incredible effort to create dedicated pathways in the hospital that were so-called dirty from those that were so-called clean. With separated personnel, wearing adequate personal protective equipment, a rapid surge in the teaching on how to use PPEs in all our personnel. Adoption of local and dynamic protocols to identify the right pathways for treatment. Let's not forget that when this all started, there was no expert, there was no literature, there was nothing that looked like evidence-based medicine. And yet we found in a hospital like the one I'm working right now, 250 inpatients that started moved from 250 largely surgical patients to 250 coronavirus respiratory patients. And that led to a complete transformation. So these had to also lead to a prompt report into a network of ICU in which all patients went from one side to the specific referral hospital in time of weeks. The key principles that led to the dedicated task force within the hospital was number one, to assure that all patients requiring admission and requiring ICU care could go through that. Number two, that we had to sustain and contain the suspected and positive cases. Again, because the last thing we wanted was number one, to infect non-coronavirus patients. Number two, to infect the personnel. And nonetheless, that happened in several cases, especially at the earliest phases of the condition. So as I said, the cancellation was immediate for 85% of elective surgical activity with a rapid step-up approach. To make one example, rheumatology took 1 week. As of March 1st, we had canceled all, if not about 5% of our patients that were supposed to come for a visit, which also translates into the fact that currently we have about 800 outpatients visit that we need to call back and attend in the next months as soon as we will start our clinics again. What was the workflow we started from? Let's start from here. patients who were suspect for coronavirus infection were arrayed according to whether they had a saturation higher than 94% or lower than 94%. This was, again, largely experience-based, not evidence-based. And I wish to say also emergency-based. 94, according to some centers, it was 92%. These were definitely suspected cases. They were triaged, and they could go into either a green pathway, which are patients that we did not consider to be highly suspicious for coronavirus, versus a yellow-red pathway. Chest X-ray to begin with. Did that make the admission likely? If that was a no, no swab was performed, awaiting discharge, and then they were discharged. If the pathway was yellow-red or the admission was likely, patients were sent to a CAT scan, which was dedicated. So no non-coronavirus suspected case was allowed to get into this CAT scan, and they all went for the swab, and then they waited for the result, and then they went for the isolated ward or ICU. At the beginning of the crisis, performing the swab and getting the results took 24, if not 48 hours, which led to the fact that all the patients had to have a gray area in which to define and to wait for the swab results. Number one. Number two, we should still consider that approximately, at least in our series, 5 to 10% of the patients were negative to the first and the second swab, and were then positive at the bronchoalveolar lavage. So that clearly complicated things, because these were patients that remained negative for several days before becoming positive, at least in the cases that we can think of. From a respiratory point of view, we decided to keep it very simple, because as at the beginning of this, we started having rheumatologists, even orthopedic surgeons attending to coronavirus patients. So we had to keep the therapeutic flow chart very simple. So we used nasal cannulas for oxygen all the way up to 4-5 liters maximum. Modified Venturi mask all the way up to 60% flow of oxygen, which is 8 liters per minute, or with a reservoir, which is a full 15 liter per minute, all the way to CPAP, and either with a helmet or with a non-invasive ventilation, and of course, all the way to contact anesthesiologists. Again, any hospital started having a flow chart like this that could be interpreted and used by any physician that was called to attend. Because let's not forget, we had all outpatients clinic closed, and the entire hospital was transformed into a coronavirus clinic. So people who had never or almost never done respiratory medicine or infectious diseases had to work from the night to the following morning on this type of patients. We also we rapidly realized that patients with coronavirus infections had an increased risk of developing thromboembolic complications. And this is not only because most patients had an elevated D dimer. And when I mean elevated, I mean all the way up to 35,000 in terms of, which is the highest limit of the method that our laboratory uses. So we prepared, we largely used enoxaparin, and we made a flow chart based on the levels of D dimer and the body weight. And we calculated how much to use of enoxaparin to prevent thromboembolic complications. And this, of course, is in the case in which the patient did not have proof of a thromboembolic complication. So this is what we did from a strictly internal medicine viewpoint. What about an immune modulation? What can rheumatology teach about coronavirus? Rheumatology became very popular with everybody with coronavirus. And that was because everyone started talking about hydroxychloroquine, about tocilizumab. And the funniest thing was to hear people who had never heard about tocilizumab try to pronounce it and misspell it in any way. I've heard tocilizumab pronounced in any possible way. So what can we say? Well, why is that? Because what we found right away is that the viral infection led to what we call a cytokine release syndrome, CRS, which is considered in a more colloquial way to be called a cytokine storm. The cytokine storm becomes rapidly and ravishing with low levels of antiviral cytokines, particularly type 1 interferons, suppression of Th1 in favor of Th2 response, but with a pro-inflammatory cytokine storm, TNF-alpha, IL-1, IL-6, probably in this order. And this order resembles a lot the order we see in rheumatoid arthritis. But even more than that, resembles a lot the order of cytokine calling to action we have seen, actually hematologists have seen in the cytokine storm that follows the CAR T treatment for leukemia. And that was the two examples that people proposing treatment for coronavirus tried to follow. Number one was rheumatoid arthritis, and number two was a CAR T cytokine storm. What we really don't know is what causes what. From my viewpoint, I think that the first days of symptoms are largely viral. It's a pure viral infection. Afterwards, we have a window of a few days, probably 2 to 5 days at the most, in which cytokines storm in and completely change everything. This is probably not clear from an imaging standpoint, in which all you see is an interstitial pneumonia. But on the other hand, what we clearly see is that blood tests change dramatically. And usually we have a significant drop in the respiratory exchange ratio. And so what we don't know is what causes what. Is the earliest phase of pneumonia related to the virus? My opinion, yes. Later on, the disease becomes more inflammatory, or if you wish, auto-inflammatory. That is why several authors have proposed macrophage activating syndrome scores to identify the inflammatory milieu of coronavirus infection. And this is what we may expect. We begin with a strictly virological phase, in which the virus enters through the ACE2 transmembrane receptor. And this has led to a lot of urban legends. Many physicians started stopping using ACE inhibitors in coronavirus, and that was completely not justified. On the other hand, ACE2 gene maps on the X chromosome. And that to me is particularly fascinating, since we know that the majority of patients who have a more severe coronavirus infections are men. And that is something we may discuss later on. Afterward, we have APC, and that leads to cytotoxic lymphocytes, which lead to the less educated response, TNF-alpha, IL-1 beta, all the way, again, TNF-alpha, but mostly IL-6, and chemokines, again, a chain that resembles a lot rheumatoid arthritis, possibly leading to ARDS and multi-organ failure. On the other hand, we have a more educated response. Helper T cells, B cells, leading to antibody response. And I know all of you have in mind a question about antibody response. We'll try to discuss that, but let me tell you right away that this is probably the part for which we know the least about this type of infection. So this is what we've been asked so far. Antimalarials, IL-6, anti-IL-1 beta, anti-JAKs, particularly baricitinib or colchicine. And we'll also touch about glucocorticoids and other mechanisms of action. But these are definitely the ones. Let me say right away that for colchicine, we don't know anything. Studies are starting right now. But if you think that, again, out-inflammatory component, the inflammasome is involved, then definitely colchicine and the neutrophil degranulation blockade they provide may be of help. Antimalarials. Chloroquine started from basic science. Chloroquine increases the endosomal pH and interfere with the glycosylation of ACE2 receptor. And so that is why it started being used both for the treatment of the earlier phases of coronavirus infection and by some colleagues, to say the least, for the prevention of the coronavirus infection. And let me say this very clear. We have no data to support either of these uses. What we do know, however, and we claim that every day in the clinics, is that hydroxychloroquine is definitely a safe drug. We all know that we have patients who take hydroxychloroquine for 30 years, even at higher doses than this, and they never develop a complication from hydroxychloroquine. So that led us to be extremely excited about using hydroxychloroquine. So at the beginning, the study was this: hydroxychloroquine plus azithromycin in an uncontrolled, non-randomized study on these small numbers led to a significant difference. Would you use hydroxychloroquine in rheumatoid arthritis if you had those data? Definitely not. But these, plus the fact that the drug was considered to be safe, led to universal use of the drug. And we did that also. So we did use hydroxychloroquine and still are using hydroxychloroquine for 7 to 10 days following admission in patients admitted for coronavirus infection. So we really don't know whether this works or not. There's at least studies ongoing on clinicaltrials.gov. So hopefully we'll have the data from those studies very, very soon. Unfortunately, starting from the first publication, which was on March 17, you see right here, this is Google Trends, how people started looking for chloroquine, hydroxychloroquine, or hydroxychloroquine shortage. But what really led to this was when Donald Trump said that hydroxychloroquine was effective against coronavirus. And this led to a tremendous impact on the use in the general population, and unfortunately in the shortage for our rheumatological patients in finding the drugs worldwide. And that was a big deal, and still is a big deal. We have patients emailing and phoning us every day saying, I can't find hydroxychloroquine anymore in the pharmacy, what should I do? So we start by reducing the dose to make it last longer, and we try to call the industry to make sure that the shortage is fixed in no time, and the patients who were taking the drug earlier are guaranteed. So what do? We started using hydroxychloroquine because chloroquine had stopped being produced, at least in our country, and we also started using direct antivirals. Do they work? We don't know. Earlier, the only data we have are from lopinavir plus ritonavir, which is what we started using to begin with, and the data is, to say the least, negative. So probably that is not a very effective treatment when it comes to coronavirus. After that, we started using remdesivir. We started to use darunavir plus cobicistat, but none of which was supported by solid data. And again, every hospital started using their own scheme, their own platform, according to the drug they had available and the opinion they had about the drug. Again, opinion-based medicine, unfortunately. Where I'm working right now, we don't use any direct antivirals, and we have not used antivirals now for 3 weeks. And I think we don't see much of a change, at least visually, in our patients. IL-6 receptor blockers, that is particularly tocilizumab, was claimed in a retrospective study of 21 Chinese patients with severe ARDS due to coronavirus infection, with one single rescue dose of tocilizumab 400 milligrams. Tocilizumab should be used at 8 milligrams per kilogram of body weight, up to a maximum of 800 milligrams IV. And this is what has been used so far, and we have some experience. This webcam is really not stable. I do apologize. We started using the drug in this way. So the Italian and both the Chinese recommendations started using tocilizumab for severe, highly inflammatory coronavirus infection. And we developed an algorithm based on the earliest Chinese data, in which biochemical indices, particularly CRP, D-dimer, ferritin, fibrinogen, and low lymphocyte count, were used and combined with a negative procalcitonin to predict the immune burden of the viral infection. So we've now used the drug in about 70 patients with coronavirus. I would love to share the data with you, but honestly, we're expecting the final analysis in 2 days. So hopefully I'll be able to share the data very soon on these type of patients. As you can see, there's different studies going on, even not really controlled. It's more of a historical controls, because everybody thought that using placebo control was really not ethical when it came to tocilizumab by itself. So most of these use both with tocilizumab and also sarilumab, which, as you all know, is the other anti-interleukin-6 receptor blocker in severe coronavirus infection. So this is probably the largest one, in which placebo was indeed used. Up to one additional dose was used. The scheme was quite subjective, if you wish, because all patients received, as I said, 8 milligrams per kilogram in one shot IV to a maximum dose of 800 milligrams, and they could be given another dose in 24 hours, between 12 and 24 hours later, if symptoms worsen or no clinical improvement was seen. As you can clearly imagine, this was somehow clinical sentiment, nothing else, because we had no way to understand how and if the drug was in any way working or not. The other mechanism is the inflammasome, and RP3 in particular, which through caspase-1, as you all know, leads to the cleavage of pro-IL-1 beta and pro-IL-18, leading to IL-1 beta and IL-1 and IL-18, which leads to the features of MAS, macrophage activation syndrome. Think of elevated ferritin levels, think of elevated CRP, think of the fever. This clearly reminds us of the MAS. So again, the usual is that we don't know. We don't know whether drugs working on MAS, this is the case of emapalumab, which is not yet approved for MAS, but is coming rapidly, or anakinra, which is a receptor antagonist for IL-1 beta, which, as we all know, is used largely in periodic fever and autoinflammatory diseases was effective. We are still waiting for the results of this trial. Another effort was based on in silico study. That is, trying to identify what potential targets of the viral replication, of the viral mechanisms, could be found in drugs already being used for other indications. And this led to the identification that baricitinib, as you all know, baricitinib is oral small molecules that is more specific for JAK1 and JAK2, which is also mediating the IL-6 signaling. So it makes sense in a way to use JAK1, JAK2 blockers to halt the cytokine release storm of coronavirus. But on top of that, this type of analysis showed that baricitinib could block AAK1. AAK1 is one of the mechanisms of the viral transportation inside the cell. So again, baricitinib could be acting through two different mechanisms in coronavirus infection. One is by blocking the viral transportation inside the cell, and the other is by blocking the inflammatory cascade related to the coronavirus infection. So this is why there is at least one study trying to identify whether baricitinib works in coronavirus infection. But we should also remember that blocking JAK1 and JAK2 also down-regulates type 1 interferon, and thus possibly may be facilitating viral replication. So we need to be extremely careful with this. And these are the studies currently being used. Particularly, this is one of them. It's an open label prospective trial in 2 weeks with particularly severe or moderate coronavirus infections, in which patients were treated at an earlier phase, mild to moderate. This probably makes a little bit sense. And it's combined with ritonavir 600 milligrams twice a day in both arms, including the active comparator control. TNF-alpha inhibitors. TNF-alpha inhibitors are a little more behind because they pay the price. You know that in the development of TNF-alpha blockers, particularly infliximab, TNF-alpha blockers were used first for septic shock. And to say the least, they did not work. And then they were used in rheumatoid arthritis. But we do know that in the case of RCV and influenza, RCV, however, is largely a more earlier age infection. Influenza seems to be ameliorated by TNF-alpha, and TNF blockers seem to downregulate ACE2 expression. And again, two mechanisms that we can imagine. That is what led a very few days ago, Sir Mark Feldman, which, as you all know, was one of the first to use infliximab in the treatment of rheumatoid arthritis, to push for TNF blockers, particularly adalimumab, to be tested in China for ARDS and other manifestations of coronavirus infection. So, and this was again proposed to be treated earlier. Let's not forget, TNF-alpha, IL-1, IL-6 is probably the chain of events that we see in this type of infection. IVIG has been proposed, but this is something that has been used in very small case series. They seem to be including viral surface host antibodies, especially anti-spike IgG, followed by macrophage virus internalization. But again, the evidence here is very, very, very thin. Other mechanisms of action include GM-CSF blockers. We know that GM-CSF blockers, both the receptor, such as mavrilimumab, or the cytokine itself, such as namilumab, are being developed in rheumatoid arthritis. In the case of the cytokine release form, it seems that blocking that GM-CSF comes earlier than IL-6. So that is why probably all of these may lead to maybe one of the causes why TNF-alpha and IL-6 are produced, particularly by macrophages. And that is why we should be probably using this earlier. And that is why all of these drugs, including mavrilimumab and also namilumab, which we're currently using and trying in the case of our hospitals for coronavirus infections. Anticoagulants, we mentioned that. Again, we know that hypoxia and probably a dysfunction of the endothelium is actively involved into the mechanisms of tissue damage from coronavirus infection. But all of these need to be developed in clinical trials. What about glucocorticoids? Are a typical example of a double-edged sword, because we do know that previous evidence, both in SARS and MERS, basically failed. And in some cases, particularly in respiratory syncytial virus infection, this leads to a stronger progression in the lung injury and may reduce the viral clearance. So that is why the evidence on these type of viruses is, to say the least, conflicting, if not negative. And that is why in the case of COVID respiratory ARDS, the only evidence there is tells to consider a short course of systemic glucocorticoids, but not to use it as a consistent treatment in all of that. And it is also confirmed by the Surviving Sepsis campaign, in which patients without ARDS should not be treated with glucocorticoids. Patients with ARDS, particularly if they're not candidates for invasive respiratory support, should be considered for a short course of glucocorticoids. So this is what we have seen in the internal medicine field, and what we have been telling our friends in the internal medicine about rheumatic drugs. But what all of these meant for our patients? Well, it meant a lot. Okay, number one, patients are very worried. We're used to teach, to educate our patients with rheumatoid arthritis or any other type of immunomodulatory treatment to be extremely careful about infections. And that is why they started emailing us, writing us, finding answers, trying to find answers everywhere, but what to do with their treatments. Should I stop taking a biologic? Should I stop glucocorticoids? Should I stop methotrexate? The second was, as I said, the logistic difficulties to find the drugs. They were locked in their houses. And most of the biologics are given only in the hospital pharmacy, at least in this country. So most patients could not go out of their homes to get the drug. Three, some drugs were difficult to find. Think of hydroxychloroquine. It did not happen for tocilizumab, but we were afraid it might rapidly. So what did we tell our patients? Well, we told them to behave like immunodepressed patients. So to consider to be extremely careful on the social distancing, on maintaining isolation, to maintain adequate and simple hygiene behaviors, to avoid public transportation, to delay unnecessary appointments or travels. So what we did was somehow an on-demand clinics. So we asked all of them to contact us and to tell us how they were doing. And if they felt like they were doing okay, we told them three things. Number one, not to stop their medications unless they had a sign of infection. Number two, to be extremely careful with any measure to minimize the risk of getting the coronavirus. And three, to get in touch with us if anything else changed. So we started a dedicated phone number that is open 12 hours a day, where everyone can call only for medical reasons from rheumatology patients. And we're getting about 20, 30 calls a day of patients who are just scared, say, hey, my neighbor got fever, hey, my brother-in-law had the fever and I met with him like 2 weeks ago. That is the typical reason for calling. Quite rapidly, we got pushed by the Italian Society of Rheumatology. We clearly said that immunosuppressive treatments did not show to be a risk factor for previous SARS outbreak. Second, some rheumatic drugs could help to better control coronavirus. That reassured our patients a lot. They said, hey, I'm already taking hydroxychloroquine. And that led to them being extremely happy with the treatment. However, we had to convince them that when they wanted to withdraw from the treatment because they were afraid of the immunosuppression, the re-flaring of that disease could be worse. Because in the case of rheumatoid arthritis, it may have meant using high-dose glucocorticoids or other type of treatments, plus having to come to the hospital, which is something we wanted to avoid at the most, as much as possible. So we also launched national registries because honestly speaking, and this is just my experience, so don't take it as any epidemiology. I have had news of very few rheumatic patients getting coronavirus infection. And that is probably related to the fact that, again, our patients are used to avoid infections, to be extremely cautious about infections, or number two, that they're actually doing well, or they get symptomatic less if they have rheumatic disease, or if they're taking an anti-rheumatic drug. Again, this is just my experience. Don't take it as any type of epidemiological value. But definitely we're starting a registry in which we're entering all our patients. And I'm going to show you just one case because I think it's quite interesting. It's one case. This is a typical older rheumatoid arthritis lady. As I said, she's a woman. She's 75. She had a positive rheumatoid factor. She already had a mild interstitial lung disease, which was stable over time. She took etanercept for 13 years. She stopped it because of secondary inefficiency. She started baricitinib, 4 milligrams a day, plus hydroxychloroquine since 2015, and she maintained a very low dose glucocortic, one of those dosages that patients do not want to stop anytime soon. And she had a whole lot of comorbidities: type 2 diabetes, dyslipidemia, arterial hypertension, vasculopathy, recurrent bronchitis, obstructive sleep apnea syndrome, chronic kidney disease. These are exactly the type of comorbidities we do not want to see in a patient with coronavirus. She came for a fever, cough, and dyspnea. Her husband had been hospitalized a few days earlier for coronavirus infection. She had elevated CRP, leukocyte with a mild leukopenia, platelet counts, elevated ALT, fibrinogen, D-dimer, troponin were all elevated, and she was positive, plus a pneumococcal antigen positive. And she had, at the CAT scan, a ground glass pneumonia in the right and left upper lobes. She started antivirals, antibiotics, a higher dose of hydroxychloroquine, She did not stop prednisone, and she continued on baricitinib. And this is how she went. She did have an increase in the inflammatory indices, you see, but she had a drop in D-dimer, and she did extremely, extremely well, and never needed oxygen support, which in a 75-year-old lady taking chronic glucocorticoids with all those comorbidities, believe me, is not the typical way we have seen a patient doing with coronavirus these days. So she did really well, and she never had, even in the earlier phases, any need for respiratory support. So finally, what do the societies tell us? The ACR told us that patients should talk to the rheumatologist about what to do. There is no data about the effect on these medications on coronavirus, but the current practice should not be in favor of interrupting DMARDs. Immunosuppressive drugs are useful to prevent a worsening. So the communication of EULAR is when you stop these drugs, you may experience a flare-up and then need a more aggressive immunosuppressive treatment, okay? So that is why we should not stop the treatment. In the event that you have a routine rheumatology appointment, ask your doctor, should I come or should I just stay home? And if the patient is doing fine, please postpone the appointment to minimize the risk of infection. And of course, just follow any type of measure to minimize the risk of getting the coronavirus infection. We also have the Saudi Society of Dermatology and Dermatology Surgery. They put them together. They came to the same conclusion. The society does not recommend stopping biologics, and particularly from that dermatologists should benefit from the risk assessment. So what is the risk of stopping the treatment? What is the risk of having this patient coming to see me? So I'm done. Thank you all for being here. Coronavirus is totally new. So the best thing about all this is that there's no expert. When we all started with this, there was no expert. Nobody was an expert. Not the infectious people, not the pulmonologists. Nobody was an expert of all this. Oops, can you, no, what happened here? Can you, okay, thank you. Can you go back to this? Thank you. This is totally new to everybody for us. In the practice, in the sustainability, in the understanding. Rheumatologists are important. Everybody's calling us for action, for understanding what to expect with all this treatment. They know how to handle any of this treatment. And funny enough, we've all been talking about tight control, treat to target. What we're doing right now is exactly that, meaning seeing patients only when the control is not guaranteed. And with this, these are the amazing people I have the fortune to work with in Milan. This is them in December 2019, and this is us 2 weeks ago. We all were called into action. All of us were called to the coronavirus world. Even the people who are working in the laboratory are now doing coronavirus projects. And this is probably the fastest and most significant transformation we've ever experienced in rheumatology. And with this, I thank you very much for your attention, and I leave it to Humira for the following part. Thank you very much to all.
Thank you so much, Professor Carlo Selmi. That was an excellent talk, and it covered almost all the aspects which we wanted to know about as rheumatologists. I think we'll close the screen. So we have a lot of questions. We have half an hour to cover about 13 questions. I had a quick question first, is whether you test or you check for levels of interleukin-6 or IL-1 before giving any of these drugs, and is that helpful to guide our treatments in the sick patients?
The answer is no. No, because we don't know whether patients we've seen that in rheumatoid, whether patients who have higher levels of interleukin-6 respond better to tocilizumab. My experience is that, my experience is actually retrospective data. Earlier retrospective data showed that patients who were not surviving with coronavirus had higher levels of interleukin-6 to begin with.
Okay.
Number one. Number two, we do see that basically all patients with the coronavirus infection have one time or another higher levels of interleukin-6. Number three, from very preliminary data, we've seen that patients treated with tocilizumab tend to have higher levels 2 days after the first drug administration of IL-6. So I don't think that IL-6 levels could cause or drive our decisions at the present status of our knowledge.
Thank you. So another question, in relationship to men versus women, we know that men are doing worse, they're dying at higher rates than women. But there's a question here from Dr. Waleed Al-Shehi. He's asking if men are even more symptomatic in the beginning. With milder disease, are they more symptomatic?
Waleed, that's a great question. Let's not forget that we have no idea what the denominator of the people actually catching coronavirus is. What I can tell you is that among the symptomatic patients testing positive for coronavirus, there's more men, approximately 55 to 45%, according to most series. And that definitely patients who are requiring more invasive respiratory support, 60 to 70% are men. So again, whether this is a different susceptibility to actually getting the infection or a different susceptibility to responding to the infection, we have really, really no idea.
Okay. So we have a question from Ahmed Abu Jamal in Dubai. Prof. Ahmed is asking, he has a patient with COVID with pneumonia. He improved on Actemra on tocilizumab, but his procalcitonin became high after the first dose. The patient was doing well. Even the pneumonic patches resolved. So why does the procalcitonin go up when the patient is improving?
Well, of course, you must rule out a bacterial infection, and I'm sure you've thought of that. But in this condition, more than ever, and until proven otherwise, clinics is what drives us. So, is the patient febrile? Do you see any worsening? Do you see any other sign of a possible sovereign, incident bacterial infection? Try to get as much a culture examination as possible, both blood and urine. And if you see that procalcitonin going higher and higher, possibly with an increasing CRP, I would probably also use an antibiotic coverage, broad spectrum, of course.
So then there are a few questions on HCQ prophylaxis. Some Dr. Dharmanan from India, he's asking, do you all take hydroxychloroquine? Would you take it yourself? And if a person on hydroxychloroquine prophylaxis or a patient of ours who's on hydroxychloroquine gets admitted and is admitted with COVID, then what's the dose?
Well, I know my good friends from India, a lot of colleagues are taking it there. Let's say, I never took it. And I know some friends, some colleagues of mine did take it. They took it at a dose of 2 pills a day, that is 400 milligrams, which don't ask me why, because there's no reason for taking that specific dose. There is no data whatsoever From a strictly virological viewpoint, yes, hydroxychloroquine seems to make more sense at the very early phases of disease. But whether this is clinically relevant in a patient who gets or is at risk of getting coronavirus, we have no idea. So I don't think that taking hydroxychloroquine is justified in any way. Number two, what dose? What we're using in our inpatients is 800 milligrams on the first day and 400 milligrams a day from that day on for 7 to 10 days maximum. Again, don't ask me why that is. That is the self protocol we auto gave us.
What about, have you encountered false positive PCR test? Not false negative,
No.
positives.
No. I've seen many false negatives, if you wish. But again, clinics is what drives us. Even more than clinics, imaging. I've seen many patients with a clear bilateral interstitial pneumonia, very suggestive. I don't want to say pathognomonic, but definitely very suggestive of coronavirus infection, with a first and sometimes a second swab negative for coronavirus, and then testing positive at bronchoalveolar lavage.
Okay, so there is a patient with rheumatoid arthritis. This is a question from Rena. A patient with rheumatoid arthritis with COVID-19 and pneumonia on methotrexate. Would you stop the methotrexate?
I would. I would, as I would in any other time of my life. When a patient comes to me and says, "Hey, I have pneumonia," I do withdraw their DMARD for a few weeks until the problem is solved. But I would do it regardless of coronavirus, in my opinion. I mean, there's really no point in not doing that until the problem is clinically solved. And I've done it and will still do it.
Okay. Two questions. Two participants have asked the same question, Dr. Raj Kiran and Dr. Sunita. How many lupus patients have you actually seen with the SARS-CoV-2?
Oh, very, very good question. Well, I know at least one of the two, so they're very good friends. They want to trick me into this, but we did a phone survey. We called about 80 patients with lupus, systemic lupus. They were all on hydroxychloroquine. Some of them were on more powerful, let's say, immunosuppressants, and none of them had any coronavirus, despite the fact that half of them had a very close contact with at least one proven case. So whether this implies the protection, whether this is mere luck, or whether this implies any reduced susceptibility in lupus patients, I really don't know. We're doing a study now with friends in China and friends in the United States. So probably next week, we're gonna have data on about 500 patients with lupus. But right now, data are looking quite reassuring.
Great. There's a question from Dr. Cesarius. He's asking about using cyclophosphamide infusion in severe lupus, such as transverse myelitis. Do we stop in this situation or not? He's not asked if the patient has COVID infection. I think he's just asking if we continue treatments with cyclophosphamide in severe lupus.
Well, it's a life-threatening condition, so I don't think you have a choice. You minimize the risk of infection, and you go ahead with your treatment of choice. Again, let's not forget, we cut down clinics, but any type of urgent procedure or treatment was continued and will be continued. And this is definitely something you can postpone even by a week.
Thank you. I'm just going to ask the participants to please send their questions in the question and answer section, not in the chat section. So we're now going back to the chat section and to the question and answer section. Dr. Suparna Guha has asked, about India, about COVID in India, whether you think that maybe there are some genetic predispositions and some populations are doing worse, maybe, or some are better. Do you think that Indians are doing better because of some genetic? Because there's a lot of theories about, Indian population and, BCG vaccine, for instance. So what do you think about this?
Well, short answer is that we have no idea. A more articulated answer, we definitely, there's been reports of different susceptibility to the infection and the more severe infection in different ethnicities. I'm aware of at least one genome-wide association study, very quick, 6,000 subjects with coronavirus infection worldwide, whether they recovered and whether they needed any type of respiratory support. And probably we get that data very, very soon. I would guess before the summer. Right now, I really have no how to answer that question, especially from other countries. Don't know. Again, let's not forget, we don't know what the denominator is, how many patients actually got the virus.
Same Dr. Suparna has also asked another question, with regards to the increased thrombocytosis. Do they have secondary antiphospholipids?
No. There's been a couple of reports of some patients developing thrombocytopenia following tocilizumab treatment, which is something quite rarely reported in rheumatoid arthritis. And in one of these cases, I know that there's been a report of it also of a lack of a lupus anticoagulant positivity. But apart from that, I wish I knew. Chances are very thin, unfortunately, I think.
So there is a anonymous attendee who's asked that you have a patient with severe COVID disease, and he has increased procalcitonin, and he's on antibiotic coverage and increased inflammatory markers like a CRP. Would you give him tocilizumab?
No. Having a suspect of a bacterial infection is, to me, is a contraindication for using tocilizumab.
That's a very important.
An active infection.
But I think that's a point for us, because as rheumatologists, we're going to be called in, and that's very important for us to take.
Definitely, yes. But you wouldn't do it even in rheumatoid. In rheumatoid, if you had even a positive, urine culture, you would first treat that and then start tocilizumab. So I don't see why you would not do it here.
There's some questions which have been answered in your talk, but again, would you be afraid to start anti-IL-17 for a newly diagnosed ankylosing spondylitis? Somebody who's got active disease and needs to be started, for instance.
No, I would not be afraid. I would not be afraid to start it for two reasons. Number one is that viral infections in the case of IL-17 blockers does not seem to be a major issue. Number two, I would be absolutely sure the patient tries to avoid getting the infection as much as possible. And number three, because there is a slight chance that blocking IL-17 may reduce also the inflammatory burden of coronavirus infection. So definitely no.
So Dr. Sujata Sawhney from Delhi, India, she asked, what kind of protective gear would you wear when you see a patient as an urgent rheumatology consult? That's in our clinics, not a patient of COVID-19, but in regular clinics. What kind of protective gear are you wearing?
I try to wear the scrubs, a surgical mask and a more protective mask underneath. I already wear glasses, so goggles are probably not recommended, and definitely wear gloves.
Okay, so no other gown and no gloves?
No. Yes, gloves, yes.
I
would use gloves for the physical examination, yes.
I think people want to know if you're wearing an N95 mask or are you going to wear a surgical mask or both?
I would wear both. I would wear both. Keep the other one underneath for the entire day, and change the surgical mask between patients, because I usually keep that in front,
Okay.
so that if anything comes to that, I just toss it.
Yeah. Okay, that's a very good point. Um, so Dr. Rajavarapu from India also says that many of our patients with lupus are finding it difficult to get hydroxychloroquine because it lasts long in the body. I mean, it's a long half-life. Is it okay to stop it for some time? How many days would you stop it for if you come across this?
When they call me and they say, I can't find the drug, I have it only for 2 weeks, what I say is, half the dose first, so it will last twice as long. And then if you still haven't found it, then stop it. A few weeks block will not be a big issue to me. So how long is a short break? The shorter the better.
It's interesting that some of our lupus patients who disappeared for years or months not taking their hydroxychloroquine have suddenly reappeared and they want their medications. They've not been taking it. So we have an anonymous attendee who's asking why many are using tocilizumab rather than anakinra, which has given good results already for MAS and anakinra. So why are we using tocilizumab rather than the anakinra?
Well, that's a very good question. Well, the short answer is that we don't have any data on anakinra yet. The longer answer is that in the inflammatory cascade, probably blocking IL-6 makes more sense, especially if we use as a map the cytokine release storm that is following CAR-T treatment. Okay. But the good side is that anakinra has a shorter half-life, has a lower probably bacterial superinfection risk. So yes, I would definitely try it, but we have no data whatsoever.
Okay. Dr. Abbas Toma has a question about the role of BCG in COVID-19.
No idea. Sorry, I'll be very abrupt here. I know many people say that getting, a positive history of tuberculosis or a BCG vaccine protects for coronavirus. I don't think there's any reason to believe that right now, or that we do anything in that sense.
Dr. Dharmanand has another question. Women mount generally a stronger immune response. He's asking, is smoking and other comorbidities a factor for men getting more severe disease? Have you found that a much greater proportion of men are smokers as compared to women? And is that a reason for severe disease?
Sure, that is one of the possible explanations. Yes, in this country, men tend to smoke more than women and tend to smoke for longer than women. So that is one possibility. And definitely patients who were not doing well often have a COPD reactivation, exacerbation of the that we see clearly in clinics.
Okay. The next question is by Dr. Nicola Badillo. Do you have any experience or comment on doing hemoperfusion to treat the cytokine release syndrome in combination with the tocilizumab?
Can you repeat that? Any experience on what?
Doing hemoperfusion.
No, I don't have any experience on that. No, I'm sorry.
Have you been using, and as an aside question, convalescent serum, convalescent plasma?
We got it approved by the IRB. We have not treated any patient yet.
Okay. Dr. Bhavna Khan, Dubai, hi. So it was assumed and also noted that elderly and patients with comorbidities have high mortality, but we also see many healthy and young people dying with this infection. Do we have any accurate predictors of this poor prognosis or outcome? Why do we suddenly see young people dying? Some young, apparently healthy people. Yeah.
Well, fortunately, we don't see many young people doing poorly. Number one. Yes, we're seeing more older patients getting getting a more aggressive disease. Many people, including us, are working on prognostic factors, how we can predict if a patient will do well or not. However, I can tell you that from the very first Wuhan series, we did a score based mostly on biochemical tests, as I told you, D-dimers, fibrinogen, CRP, ALT, LDH, CK as well, and procalcitonin, combining the odds ratios for a negative outcome. We were capable to create somehow an algorithm over the more inflamed patients that were more likely to do poorly. But we have not confirmed that in an independent cohort, and we're looking forward to that.
Tariq Islam says that there are patients who have improved and now asymptomatic, but the swabs keep coming back positive. What is the safe policy for discharging them?
Well, we discharge them as far as if they have no clinical reasons for being in the hospital, we discharge them without a control swab. In this region, they do the control swab after 2 weeks of being home. So we discharge them and we ask them to keep isolated from anybody else, either at home. So we ask them to have a room and a bathroom for themselves only, or in hotels. We basically have two entire hotels which are dedicated to convalescent people that have gone out of the hospital and need to be isolated from their families. And until they don't have a negative swab, they need to be isolated. That's what we do here.
We have so many questions coming in. We're going to be running out of time, but we'll try to we have a few more minutes, 5 more minutes, I think. Dr. Sapan Pandya from India, he's asking, what is your view on the current iron dissociation from beta chain of hemoglobin and resulting iron toxicity causing the lung problem and role of plasmapheresis or infusion?
These are all excellent candidates. I have no experience on either of these maneuvers. If you look in clinicaltrials.gov, there is right now 650 clinical trials on coronavirus. 650. What we really don't know is which patient will benefit the most from which treatment. So chances are that using any drug in the wrong patient may give the wrong result. Okay, I'm not sure if I'm making myself clear, but yes, what we're saying, beta chain, working on the beta chain would make sense. But whether doing plasmapheresis in patients with coronavirus makes a clinically relevant effect, that's a totally different issue. And right now, the answer is another, we don't know.
Yeah, so many things we don't know.
Sorry, lots of we don't know. I'm sorry, I'm very sorry.
I hope we are right at the beginning of this and this is the end as well.
Yeah.
There's so many more questions, so I'm going quickly through this. Suppose a patient is taking tocilizumab already and gets COVID-19, would you stop it? Would you stop the tocilizumab?
No, I would not. I would actually continue it.
So even a JAK inhibitor, you would continue?
Well, that's what we did. Let's be, okay. Tocilizumab anyway has, I believe it's about 8 days half-life, 8 or 9 days. So stopping it doesn't make too much sense to me. Anyway, because you will see in 6 days, 5 days, 4 days, you will know whether how the patient will be doing. And in the case of baricitinib has a 13-hour half-life. So that is a completely different issue. So it's easier to stop it and reintroduce it. If you don't have any idea of a type of infection, other bacterial infection, I would not stop one of these candidate drugs.
Okay. Dr. Jamal Ibrahim from Dubai asks, taking into consideration the asymptomatic carrier rate, do you recommend COVID-19 screening on new patients to be started in biologicals? And if so, how many negative swabs would you consider?
I recommend a clinical study on this. We don't know. We don't know how to deal with asymptomatic patients being positive. I would probably not recommend unless the symptoms or unless there's there's a very clear risk of a risk of getting the infection. That is a close relationship with one developed case.
Okay. I think many of the other questions you've already covered in your talk or are repeats, but there is an important topic about the antibody tests. I know we are not, everyone wants to know if they're immune. Patient came into my clinic today, and with this regular blood test, he told my nurse, please add the COVID-19 antibody test. And we are like, okay, so.
In Europe, there's currently, I think 75 different ELISA tests for IgG and IgM against coronavirus, none of which has been clinically proven to predict whether the patient is protected against the virus. What we may assume, provided there is no cross-reactivity, is that that subject, not a patient, that subject has come into contact with coronavirus. But whether he or she is still infectious, whether contagious, whether he or she is still is protected against the infection, we have no idea. So doing the test at the present state of knowledge makes no sense whatsoever.
Thank you.
Am I clear enough?
Very clear. Thank you so much, Professor Carlo Selmi. This was just excellent, and you benefited so many people who've attended from around the world. We thank you so much. I'm so sorry for all the attendees who have so many questions. There are like literally so many questions, but we can't get to all of them. But thank you so much. This was amazing.
Oh, thank you guys. It's been a great pleasure. I have lots of friends in all these countries, and I'm truly honored. You're close to my heart. Thank you very much for being here, and I'm sure of your thoughts and prayers. And thank you, Humira. You've been an incredible host. Thank you so much.
Good luck to Italy. We hope you flatten the curve quickly and come off this.
Oh, definitely. We'll be back in no time. Believe me, we'll be back traveling and hosting you. Come visit very soon.
We hope to very soon. Take care.
Take care.